And good evening, everyone. Thank you for your patience. And today we'll be having our fireside chat, number 193. Our topic for this evening is going to be CKD prevention. And we're going to look at a question. Is a learning public health system a paradigm the answer? So our guest speaker for this talk will be Dr. Rajiv Saran, who'll be taking us through this topic. He is a seasoned professor of internal medicine and the Florence E. Bingham endowed chair in the Division of Nephrology at Department of Internal Medicine at the University of Michigan and practicing nephrologist at the Arbor VA Hospital. He is also a professor of epidemiology at the University of Michigan School of Public Health. Dr. Saran's research team is based at the University of Michigan's Kidney Epidemiology and Course Center. He is passionate about the prevention of kidney disease and related chronic diseases nationally and globally. Dr. Saran is an internationally recognized expert in kidney disease research, specifically in kidney disease surveillance and epidemiology. He has served as director of the United States Renal Data System, abbreviated as USRDS, which is a gold standard for the kidney disease data system worldwide. He served from 2014 to 2019, and for nearly 2 decades, he has led the Center for the Disease Control and Prevention, that's the CDC, National CKD Surveillance System for the US, that is from the year 2006 to date, which is focused on upstream surveillance of CKD using multiple data sources in the United States. Dr. Saran has also led the development of the first national kidney disease information system, abbreviated as VA-RAINS, from 2012 to 2016, for the Department of Veterans Affairs. His recent work has focused on improving surveillance systems for greater public health impact, utilizing social and environmental determinants of health data towards tackling health disparities, while developing and evaluating the use of prediction analytics to help inform earlier stage prevention of chronic diseases, with kidney disease as an example. In 2023, he received a Lifetime Achievement Award from the American Nephrologist of Indian origin. He is currently the editor-in-chief for the International Journal of NCDs and has over 230 peer-review publications in prestigious journals. So this is going to be an interesting and enlightening topic that we're looking forward to. And for now, I'll hand it over to Dr. Saran. Over to you.
Thank you, Yuri. Thank you very much for that very kind and extensive introduction. Now you raised expectations, but time is short, so let me start. Thank you for this invitation. I'm delighted to be here. And yes, I have been involved with the surveillance of kidney disease, which meant mostly observational studies and looking at data and presenting it and then publishing it or putting it on a website. But for some time now, I've been wondering, why are we doing this? You know, what impact is it having, etc. So that's the motivation behind this talk. And I've been fascinated by this concept of the learning system or the learning health system, which I think needs to be applied not just to the health system, but also beyond in the public health arena. And combining the two might be the answer, but that's a hypothesis that I'm putting forth. So we've just had the World Kidney Month, and the focus there was understanding the importance of kidney health testing, not just for kidney disease, but evaluating people's health and in general, kidney health in particular. So that was the theme for the World Kidney Month. And the other thing that motivates me is this saying from Henry Ford, which is not far from here, Detroit, where the car industry was, that if you've always done what you've always done, you'll always get what you've always got. And I think that thesis is very important, that we need to think of new ways of approaching conditions and diseases in this case, and kidney disease. So all of you are very familiar with the epidemiology, but I'll run through some basic facts. This is in the United States, approximately 40 million people, US adults, not including children, because we didn't have the data a lot on children, prevalence in children, are estimated to have CKD. That is more than 1 in 7 adults, and approximately 1 in 3 adults with diabetes have chronic kidney disease. These are well-known facts, and this picture is adapted from the CDC's kidney disease facts, fast stats on kidney disease. Awareness is very low, as you all know. 9 out of 10 people, certainly even in the US today, who have kidney disease do not know that they have it. And the awareness certainly goes up, as the graphic on the left side shows. With the stage of kidney disease, the more advanced the kidney disease, more people become aware of their kidney disease, because by then it becomes symptomatic. So these are well-known facts. Here is some information that display of data from the US, again, mapping poverty and CKD based on some recent geospatial work and data visualization in the CDC's kidney disease surveillance system project, showing what is known as a bivariate map, which shows 2 variables if you look at the insert below, CKD prevalence, the colors are showing from low to high, and poverty thresholds from low to high. So high poverty, and both combined will be this dark blue. So if you focus only on the dark blue areas and lots of colors in between, that you'll see that there are lots of pockets where there's high poverty and high CKD prevalence. This is diagnosed CKD, not CKD by labs. So there are limitations to these data, of course. This uses claims data or billing data for CKD. And all this goes to show is that kidney disease is a poster child for disparities, that it's occurring a lot in areas that are poor, but also occurring in other areas that are not so poor. So the correlation seems to be there, but you cannot draw causal inferences just by looking at this picture, but it's a useful snapshot of the issue. Here is some work that we did in the US Renal Data System project, where we looked at the relationship of age and cumulative incidence of end-stage kidney disease from birth. So on the y-axis, you see the cumulative incidence percentages, and on the x-axis, age in a cohort that was aged artificially, looking at people from age 0 to age 100 plus. It's a projection kind of thing. And this estimated the cumulative incidence of ESKD from birth to age 100 by race and ethnicity. The left panel shows men. On the right, it's females. As you can see, both the graphics, both the lines and the graphs are looking very similar, except that the one for females shows slightly lower lifetime incidence of end-stage kidney disease compared to males. And the highest curve here, the highest line here, represents African-American adults living in the US. Non-Hispanic whites are right at the bottom here. So the lowest annual lifetime incidence. So this is well known. And the other races like Hispanics and others, the mean incidence, cumulative incidence, is shown in the dark dots, which is about 4% as a lifetime risk of end-stage kidney disease. So it's a fairly rare condition, as you know, but nevertheless, this was the first time we looked at cumulative incidence or lifetime risk, if you like, because incidence rates, we are used to showing incidence rates in the surveillance, but not the lifetime risk. So this was a slightly different tack on this. I don't think the current USRDS is actually showing lifetime risk, but it can be computed and showed. This was out of interest, and we published this back in 2016. The next slide, I think I took from a recent Canadian publication, which I think is very interesting. They look at, if you look at the graph, if you look at the circle first, that most of the people with CKD are unaware of it, and they have not been told, they have not been diagnosed. Maybe that's because they have not been tested, or they haven't developed symptoms. So it's only about 7 to 20% that are aware. This is from Canadian data. And it's only that once people who are aware have been told that they have kidney disease, and then among those, then we start looking at quality metrics like proteinuria monitoring, blood pressure control, hemoglobin A1C, etc. So we are looking at a small fraction of the people that have kidney disease that have presented to us, and then we have told them that they have kidney disease and are potentially getting or not guideline recommended care. So it's kind of a small, we are dealing with the small population that presents to us. Vast majority of kidney disease is out there, undetected and undiagnosed, and therefore people are not being made aware, because it's only when a physician or a provider, either a physician or a nurse or somebody else, tells them that their labs are consistent with kidney disease, that people become aware that they might have kidney disease, etc. So it's a huge problem, but we are only tossing and turning about the people who are aware and who are presenting. And should we be doing better than that is the bigger question. A global scale, I guess these are statistics from the combined statement from ASN, the European Association, and the ISN. Kidney disease is projected to rise from the 10th leading cause of death to the 5th spot worldwide, by 2040, not that far off. And it's rising in importance. A lot of people have it. And it's more than diabetes. So it's very few people realize that the prevalence of CKD is more than diabetes, more than cancer, and perhaps even the acquired immunodeficiency syndrome. I know that's a huge problem, has been a huge problem, now under better control in Africa. And I'm not an expert there, but kidney disease certainly is a silent pandemic, if you like. And that's often not real. This audience obviously knows that, but it's a problem. So what is our approach to prevention? And I hearken back to this concept that was enunciated back in 1992, showing approaches to primary prevention. Okay, we're not talking about secondary prevention here, but for primary prevention, there's a strategy shown on the left and a strategy shown on the right. The strategy shown on the right is what we normally do. We take people who we think have risk factors, and then we focus on them, and we try to shift this curve, the health distribution curve, to the healthier side. So in this case, the risk factor, we're trying to move this graph to the left because the distribution of the disease is high, and we are trying to make the entire population healthier to make it move to the left, to the green side. If we only focus on the ones that have high risk, then we are only shifting the curve very slightly in its extreme, but we are not shifting the entire curve. And population health experts have emphasized that it's important to shift the entire population, not just those with identifiable risk factors. I think this is the approach we normally use, and is somewhat short-sighted and only has a small impact, but that's sometimes what we can do at best. So that's the one that's normally followed. But I put it to you that the better approach would be to try and improve the population, the entire population's health, by targeting the entire population and seeking even small changes in highly prevalent risk factors to prevent complications therefrom. And that is the more radical approach. So this is one concept that it needs a reminding. I think this is from 1992. The other concept which I'd like to put forth is, again, something that's not brand new. It was published in JAMA in 2016, but I don't hear people talk about this a lot. We talk about the individual, there's academic systems third curve concept, or for public health improvement, sort of as a follow-up to the earlier slide that I showed. And what we should be aiming at is to move the entire population to the right side. And the way we can do this is not just do the first, the initial priority is just to take care of patients that present to us. Fee for service in the US is the predominant payment model. In the second stage, we've started doing population health management. So among the people that come to us, we try to manage their health even after they leave the hospital or they leave the clinics. And we have limited budget, so we have to deal with that population. But the third curve is where health systems take responsibility, not just for people that come to them, but for the population that surrounds them, broader population health improvement. If I'm a health system in Michigan or in Ann Arbor, city of Ann Arbor, then I try to improve the health of the people in Ann Arbor. And if that's the motivation for the health system, then it can have a bigger impact to enhance health of all individuals, requiring greater emphasis on factors that are or influences that are unrelated to healthcare. So that's what this graphic is trying to show: the first curve, the second curve, and the third curve, which is likely to move populations from unhealthy towards the healthy side. So as was mentioned, Yuri mentioned that we are been involved in this kidney disease surveillance system funded by the CDC, now in its fourth 5-year cycle. But really, it is a stop and start project. It gets funded for 5 years, and then we start afresh, and so on. So it's not a continuum, and it was a continuum for the first 15 years. But in the last 5-year phase, the CDC had us take down everything, and we had to start afresh. So the entire website was taken down. A new team, our team, took over the entire project. It was no longer shared between two different institutions. So there was a new leadership, and they asked us to change everything. So now the website actually is more concentrated. It's limited to a few important metrics, and we are continually making changes. It's a very detailed website, and this is just the landing page, but it has prevalence, awareness, risk factors, outcomes, quality of care, and social determinants of health, which was added in the most recent phase. And it's about tracking and attempting to prevent kidney disease in the United States. And I think that's the motivation that certainly as the project director, I'm trying to envision. So the vision and mission of this surveillance system is to position ourselves as a continuously learning and dynamic public health surveillance system that takes the data to knowledge and then to action, promotes action or policy change or changes within health systems and areas for kidney health and kidney disease prevention. And the CDC would like us to raise awareness of kidney disease. Of course, that's extremely important, and its risk factors throughout the country, and help guide policymakers, health providers, stakeholders, other stakeholders, in fact, every person, to take action to prevent kidney disease in the country. As I mentioned, there are major topics that we are covering listed on this slide: incidence and prevalence, awareness, very typical social and environmental determinants of health. That's what it stands for, this abbreviation, health consequences, etc. So those are the main topics. There's no one healthcare system in the United States. It's not integrated like in many countries in Europe or Sweden, Norway. They have the entire country's health system is in one database. The UK health system, for example, the NHS is like that. And that's great, because then they can look at almost everybody who presents to the health system in the entire country. But we are not so fortunate. So we have a bunch of different data sets, and we've decided to combine information from different sources. There are national surveys, there are private health systems, health insurance data. Sometimes they have lab data, other times they don't. We have the federal agencies that have their own systems. The VA health system comes as close as it can to a nationally integrated health system, but it deals with a special population. If you combine the DoD, the Department of Defense, and the VA, the retired Army officials, Army veterans, soldiers, as well as officers, then you have a more representative population. But again, it's mostly men, small proportion of women. Medicare deals with 65 or older. Medicaid is poor population, disadvantaged populations, but these are mostly claims data. They're mostly billing data, so that doesn't have lab information. But nevertheless, when we put all this together, we can get fairly useful information about kidney disease and other conditions, related conditions. In the background now, there has been development of these so-called federated health system-based data sources, like the National COVID Collaborative, abbreviated N3C, the Patient-Centered Outcomes Research Network that brings together different health systems that are beginning to share their data across electronic firewalls. And then there's a background of rich environmental and social determinants of health data from public surveys, like the American Community Survey that's done as part of the census every 10 years. So there's a lot of information out there, and big data streams that we are lucky to be able to deal with. But again, it requires bandwidth, it requires a lot of funding to do this. And CDC and other agencies are not always so generous. They give us limited funds, so we have to do what we can within that. So given that background, I just wanted to highlight public health surveillance definition. Most of you may be familiar, some of you may not be. For those who are not familiar, this is an old definition of surveillance for public health, which applies to both infectious and non-infectious diseases. And it's an ongoing process, systematic collection, analysis, interpretation of health data, essential to planning and implementation, etc. Again, closely integrated with timely dissemination. That's a very important characteristic of surveillance. If it's not timely, it's not useful. And then it has to be disseminated to those who need to know. And even though we have this beautiful cycle that everybody draws centered on any health problem of interest, and everybody says, yes, we understand what surveillance means, really they stop here. It's a dead end. They stop after interpreting and dissemination of the data, and then they hope that others will take care of it, or somebody will intervene and try to improve the situation, linking to the public health practice. Therefore, I'm suggesting that it's the weakest link in this circle of events or cycle of events. So this is an old concept. It's a very good concept, but it's limited because the delays happen here. So what is a learning health system? And as an extension of that, what is a learning public health system? The concept is that a learning health system, and therefore a learning public health system, is more of a development of not just a data infrastructure, but a socio-technical and cultural infrastructure. It's got a big infrastructure need, but it's not just a data structure, database, or a registry. Those are limiting terms, but it's a cultural change. A lot of stakeholders need to be involved and come together to serve society in an ecosystem that values data, that values health, well-being, healthcare quality for its citizens. And throughout this, the equity and equitable distribution of resources and efforts for effective policies and actions. So it's a more all-encompassing, more energizing, more idealistic, if you like, concept that so far has been applied and studied and tested since 2007 in the United States in limited fashion in different health systems. And here is the concept, and I am very grateful to Dr. Chuck Friedman at the University of Michigan. He actually is the first department chair for the Department of Learning Health Sciences, one of the very first departments of its kind in the US. And he keeps showing us this picture. And I'm sure if some of you have heard his lectures, this is the central theme. This is the learning health system, virtuous cycles of study and change. It starts from formation of a learning community that comes together, stakeholders, they focus on a health problem of interest. In this case, it's chronic kidney disease. They try to capture practice in the form of data. So in health systems that have electronic health records, or people are energetically collecting information, this is great. Data is assembled, data is converted to knowledge, interpretation, and then you design interventions within the health system iteratively to improve performance, and then you continue to capture the practice as data. This is the main concept. And then when I looked at this for the first time in 2018 with Chuck Friedman, I said, this looks identical to the surveillance cycle. So on the surveillance cycle, which I just showed you before from 1988, is shown on the left side. And the modern day learning system or learning health system also has a health problem of interest in the center, like you might expect. And it's data collection, analysis, interpretation, dissemination, change, and continued surveillance. But what it doesn't emphasize is this formation of a learning community, or bringing together, or making iterative changes in a timely manner on the go. I think this is surveillance on steroids, if you like, or surveillance with data availability, big data availability, current data with electronic EMRs, et cetera. And I realize not every health system and not every country or state in the US has an EMR, but it's becoming more widespread. So with that, I think this more energetic surveillance, if you like, more real time, which became apparent during the COVID pandemic in the US, where there were a lot of good current data being disseminated. And in the UK and Scotland and other places, they were learning health systems which learned rapidly from their ongoing experience. But that was in the setting of a pandemic. I put it to you that chronic diseases should also be looked at with similar energy and interest, and surveillance systems or learning systems be developed in areas that don't have these, at least in concept, and then the infrastructure follows with appropriate investments in technology and energy. Skip this slide. So CKD is a global health priority. You're all familiar with the various stages and the tip of the iceberg, which we've been dealing with for a long time, when GFR drops very low. And certainly earlier stages are missed because, GFR changes can occur. The EGFR formula is inaccurate. But I just want to bring your attention to the definition of CKD. That's very simple definition, and we complicate it a lot. It's only defined as abnormalities of structure or function present for greater than 3 months with implications for health. So it's a qualitative definition. The stages are very good, and it doesn't, but people are so obsessed with staging and things that they forget that the fundamental definition is fairly qualitative, and if any abnormality is present for greater than 3 months, which is again arbitrary, with implications for health. So not everyone that has slight decrease in function or which is present for more than 3 months, which they may have been born with, which may not give them any health problems. So all these things have to be taken into account. Again, I'm not going to spend too much time on this. You should be familiar with that. And also the KDIGO, the classification is very important. I think most of you are familiar with this grid, this heat map or heat table, if you like, that tabulates glomerular filtration rate categories, stage 3A, 3B, and then the 3 categories of albuminuria. The reason I'm showing this is because there is controversy in these early stages. Even KDIGO has failed to call these kidney disease at the moment. When albuminuria is less than 30, when GFR is greater than 60, the definition is fuzzy. If you read the guidelines, they talk about screening this group, but by and large, practitioners, nephrologists, maybe they are paying more attention now to earlier stages, but certainly this is not the norm. Somebody has 20 milligrams per gram of albuminuria, generally it's ignored in clinical practice till it reaches the stage, the A2 stage or category. But the data suggests that you should be paying attention to this early abnormality. If you are serious about prevention, primary prevention or early secondary prevention, I think that is extremely important. This green zone portends future risk and should not be ignored if you need to prevent. You should be looking at risk factors. You should be actively managing those people. But currently, that's not being done, and therefore awareness is low in early stages, and it only becomes more. So part of the reason why we are landed with this low awareness is because we don't pay enough attention to earlier stages. But that's a thesis that it's a retrospectoscope view, but I think it's important to take it forward. These are data slides that from the CKD Prognosis Consortium that have shown elegantly, time and time again, multiple studies, different cohorts put together, meta-analyses, very impressive work that shows you the relationship between both GFR and serum creatinine. This slide is mostly focused on the GFR using both creatinine alone on the left panels, creatinine plus cystatin C, which is increasingly being used, certainly in the United States, in health systems. And more people are doing that in order to confirm or to manage patients where creatinine alone may not be a reliable marker. But looking at this, if you look at the graphs on the right, just for argument's sake, the takeoff of risk occurring below eGFR of 90 is more apparent when you use creatinine and cystatin C than when you use creatinine alone. But if you look at down here, the hazard with creatinine alone actually does begin to rise below 90. And of course, it's creatinine alone is relatively unreliable in the very low creatinine levels because of muscle mass, malnutrition, etc. Whereas if you use cystatin C, that inaccuracy is, the precision is gained by adding cystatin C to the formula. And this is looking at all kinds of outcomes, not just end-stage kidney disease and acute kidney injury, but a whole host of cardiovascular events. So the risk for all these conditions is going up below an eGFR of 90. And if I were to show you data related to albuminuria, it's very similar. It's a continuous relationship, right from the earlier less than 30 milligrams per gram of creatinine level. So it's important not to ignore that. I feel in clinical practice, maybe you should repeat it, confirm it, etc. But it's important to pay attention to that. I think this slide does capture that data for higher risk, even in the low albumin excretion or so-called green categories. And then, of course, things get worse as albuminuria increases or GFR drops. And this is a study, again, from the CKD Prognosis Consortium, just showing that the risk ratios in greater detail. But suffice it to say that this is huge number of people. This represents a huge number of people, but we tend to ignore it simply because they're asymptomatic. These are very small amounts of albuminuria that are typically ignored in practice. So that's the point I wanted to drive home. Again, they're looking at a series of adverse outcomes, not just end-stage kidney disease. Then we move on to this new syndrome that's been described, that for the first time, kidney finds a central place in the so-called cardio-kidney metabolic syndrome. This is a nice recap of what has been known for a long time and putting together of a vast body of literature. I think I commend the American Heart Association and all the people that took part in the roundtables and discussions and review of literature that said, hey, we are dealing with, there's a big elephant in the room, depends who's looking at it, which specialist is looking at it, that perfect health is rare. Actually, perfect health among US adults is extremely rare. Only about 15% of people in the US fit in this category of stage 0 without any risk factors. And of course, if you're here and you want to stay here, you got to focus on primordial prevention, preserving your cardiovascular health through all the healthy habits. But if you already have visceral obesity or generalized obesity, you're already in stage 1. There may be some impairment of glucose tolerance or pre-diabetes or early metabolic changes, but it's primarily obesity or harmful obesity. Stage 2 is the metabolic risk factors. CKD, early stage, moderate to high risk even, has been included in this non-metabolic etiologies it focuses on. And then as things progress, there's subclinical CVD, which I think most people above the age of 45, if you really test them, they'll have subclinical CVD of some sort. Maybe it's not clinically relevant or manifesting yet, but preventive efforts should continue. And then, of course, clinical CVD, which is the extreme stage where kidney disease has stage 4 and 5 are included. So it's a spectrum. And, these risk factors are overlapping, and they've artificially defined these 5 stages from 0 to 4. But I think this concept, which has just been promoted, this was published end of 2023, so it's not that old, but there's a lot of interest in this, and people are characterized. There's about 10, 12 publications out so far, and there's a lot of interest in the Kidney Disease Surveillance System project. Certainly is interested in exploring this further. Huge amount of excitement, not just because of the CKM syndrome, but even before that, particularly for diabetic kidney disease and kidney disease in general. A lot of excitement with multiple new agents being available, SGLT2, GLP-1s, non-steroidal mineralocorticoid antagonists. Of course, the fundamentals of renin-angiotensin inhibition and statins for those 50 and older are guideline-based therapies. But we forget, it's good to talk about these pillars of management, but people often underemphasize the foundation of these pillars, which is, I think, even more important than drug usage alone, because you can get into polypharmacy, especially in the older, and get more side effects and so on. While it's good to use these drugs when indicated, please don't forget the foundation, which is often given two-liner. And then, but in practice, it's hard to implement. It's easier said than done. And unless you have systems in place to really change people's habits and behavior, it's the hardest thing to do. And perhaps a more important way of dealing with that is to tackle social determinants of health, that the environment, the community development, reduction in poverty, improvements in access to healthcare, etc., and a general awareness of these conditions. But that's a hard nut to crack. Nevertheless, I just wanted to emphasize, I'm not going to go into details of the clinical trials and so on. So for those of you who are expecting that, that was not the focus of my, but this is a huge, and newer drugs are coming out, large clinical trials convincingly showing that the drugs do help. But I think that they help in moderate to severe cases, which are important for us to deal with as practitioners. But for prevention, for earlier prevention, I think the lifestyle, the social determinants of health, and judicious use of some medications, I think, is the key. So I'm talking about social determinants of health, which are very, very fundamental in terms of taking care of people's or communities or places, and may explain up to 50% of health disparities. Certainly in the US, it's been suggested that up to 50% of health is determined by your social, where you are born, the zip code, and the type of upbringing or environment that you've been exposed to, and that clinical care is only about 20% contributor to health and health outcomes. Of course, everyone over time will decline, and age is a real thing, and aging is a real phenomenon, but you can slow it down and improve quality of life. So these are the various social determinants of health broadly. Economic stability is underlying much of this. Social and community context. I think if you look at the blue zones, these are the very important. Social connections are very important for health and well-being. The neighborhood, the built environment, especially in these days of climate change, making neighborhoods more climate resilient, healthcare access and quality of healthcare, and then education. And these are some of the major social determinants of health. And this diagram I like is, if it's a cartoon that shows people swimming in this river, of having fallen from this broken bridge. They keep falling into the river, and then they float down. We try to rescue them when they're about to go down the waterfall. Sometimes secondary prevention helps in this part where they can be rescued. But really, we need to fix the bridges and prevent disease early. So this paradigm shift has to take place, and answers may lie upstream. So we've done some empirical work in this area, and I want to show you some data that my team, and especially folks from LabCorp, I'm very grateful to our collaborators in LabCorp, one of our senior analysts and programmers and epidemiologists, Dr. Jennifer Bragg-Gresham, and others, social scientists and data scientists on our team. This is a manuscript in preparation, where we showed that in Detroit, which is a city in Ann Arbor, where there's a large proportion of African-American people that live there, have always lived there, that in the early or mid 1930s, there were housing discrimination laws that were the legal framework at that time. And this is a map of Detroit City. Separates Canada is over here. This is Detroit. Ann Arbor is somewhere to the west. We are somewhere where this text is written here. Focusing on the red lined or the red zones here were areas where loaning companies, the banks, would not loan money to people living in those areas. And these areas were deemed not so desirable. They were classed as D, and then there was A, B, C, D. And so there were 4 grades of places, basically drawn on a map. And this was the legal framework of the lending agencies. This is called redlining, if those of you are not familiar with this term. So there was active housing discrimination, lending discrimination being practiced, one of the structural forms of racism back from the early 1900s. And when we now look at these maps, Now, this was outlawed. This practice was legally outlawed. The government says by 1960, these were outlawed. But even when you look at the situation today in these areas, and you look at hotspots of kidney disease using lab data from a large national chain, national laboratory, ignore this side of the map. These are the lakes, part of the Great Lakes. This is Canada. This is the Detroit region. That there are huge hotspots of kidney disease, diabetes, and other chronic conditions, cardiovascular conditions. The blue areas are the areas where there have been changes in business investment and more people moving back into Detroit. And but there's this huge hotspot of kidney disease, diabetes, obesity, and also high CRP levels. And we've just mapped any indication, meaning either GFR or albuminuria prevalence. And then if you look at albuminuria alone, there are hotspots of albuminuria concentrated in these areas when we look at the existing lab data. This is not a screening project. So far, we are just looking at existing data. And we want to be able to do more of this kind of work. And we are trying to look at associations. And I don't think I'll have time to go through all the tables and figures, but in essence, the current day social determinants of health in the areas that were redlined in the past are still seen to play a role in worse health status in these areas. And the factors that we found highly predictive of kidney disease, diabetes, mainly focusing on kidney disease, was the prevalence of rental housing. So more people renting areas, still people that don't own their houses in that area. Air pollution in pockets are higher because their homes are located closer to the industries where they work. Education facilities are lower. There people there are not as well educated, and low incomes show the largest association with poor health. Not surprising, but these data are very stark, and we are very impressed that these kinds of investigations should allow us to focus on regions that need most attention. And therefore, we think that these social determinants of health, amongst others, may be prioritized for investment and designing potential intervention programs aimed at improving conditions and reducing the legacy of unjust housing policies in the US. So it's troubled times again, but I think hopefully we can do. There's some data that I could show you, but let me skip over these slides. Again, just give you an example. For example, the reference is the D zone, where the population is the poorest, has historically had the lowest housing facility. These are crude data. Again, we looked at a whole bunch of lab information, different laboratory tests, and whatever you see a gradient. Basically, you see a gradient of lower risk in this is crude again, not adjusted for things. When we did more sophisticated analyses, and I can show you here that renter occupied housing, this is using mediation analysis, and these are odds ratios adjusted for age, sex, and mostly adjusted for age and sex, but not other things. But when we look at outcomes such as diabetes using hemoglobin A1C, kidney disease, very high risk in renter occupied, more air pollution, less education, lower incomes, employed but do not own an automobile was not that important, but uninsured were more, etc. So there was, if we focus on the top 3 or 4, I think that might lead to the best impact, is what we think based on these causal analysis that we've tried to do using a technique called mediation analysis. We've recently developed risk predictive modeling equations using data in the US Veterans Health Administration. We had a special project from the Department of Innovations at the VA. These are side projects. These are not part of the kidney disease surveillance system, but other funding streams. And we've developed a prediction model using allow us to use a data-driven approach for implementation programs to reduce the incidence and then progression of kidney disease amongst US veterans. But this, I think, can apply to other populations, and we have validated it in the Michigan health system, which is more like the general population in the US. There were several models for new onset or newly detected CKD. And as you added more variables, the C statistic or the concordance statistic became higher, but there was no further gain beyond adding comorbid conditions, demographics, laboratory data, some medication data, and laboratory data. We reached up to 0.83, which is a pretty good C statistic. We've done the ROC modeling with this framework, and then we can come up with sensitivity and specificity and how many people are needed to be screened in the VA health system to be able to detect, to get the biggest bang for the buck. And this allows us to do that. We calibrated these data, calibrated well in Michigan Medicine, which is another health system. And certainly these external validation in Michigan Medicine looks good. So far, it had excellency statistic of 0.88. In fact, it was better than what we saw in the VA. So for some reason, the model developed in the VA performed better in a regular health system in a certain geographic condition. And certainly we need to validate in other health systems, but this was very reassuring. And so we think that because it's externally validated, we can use this in an electronic medical record system with the decision support to allow for early detection of people at risk. And then looking at, we've also done similar study for progression, and that also did very well. And we are involved in some pilot studies now, planning implementation projects within health systems. But of course, everything needs funding and so on. So these are preliminary data. Talking about screening, I think one of the best papers that's out there by Schlipak, Mike Schlipak and others, emanating from a KDIGO controversies conference. Some of you may have had the privilege of attending this one. I did not go to this one, but it lays out the framework for who should be screened, risk stratification, and then therapy. I think this is one of the best articles I've read on screening. Currently, as you know, there are no general guidelines for screening for kidney disease. Despite a lot of information, the KDIGO guidelines don't address screening. They're mostly about diagnosis and management of kidney disease. They don't commit to talking about screening, but I think hopefully guidelines will come. The US Preventive Task Force is still mulling over this, but their standards are too high. They're not going to recommend screening. But there were several takeaway messages from this KDIGO controversies conference, which I urge you to read this paper. And they came up with 13 recommendations. And they wanted to help, stimulate folks to go beyond diabetes and look at other risk factors for screening, certainly higher risk individuals and populations, but also consider environmental exposures or genetic risk factors. And said that screening should be individualized based on their risk profiles and so on. So it's a complicated framework, but makes a lot of sense. I think this is the best paper so far on screening. And I was earlier talking about this concept of the CKD blind spot, which has been highlighted in recent literature. This early stage detection is very important. We are missing this as nephrologists. We are not focusing on this early cardiorenal risk. I think with the CKM framework, this will become more and more, hopefully, the norm. And we pay attention only when GFR drops below 60. So we are focusing on only 25% of people who potentially have kidney disease, and the others are being missed. And this may be the reason why there's low awareness of kidney disease. So the solution is implementation of albuminuria detection early, and albumin to creatinine ratio. And certainly the thesis is that the new drugs and all the new approaches will help in management earlier. Don't forget the foundation of treatment, other than in addition to considering drugs, which are very exciting field. And perhaps there should be earlier biomarkers to detect people sooner. The clinical problem is huge. There's early cardiorenal risk. We detect people when it's too late, and then we wonder why there's more and more late disease coming to our doorstep. repeat that. But in essence, what I've been trying to say, and this is my couple of concluding slides, what we are trying to develop is a place-based, in addition to a person-based, a place-based approach to disease prevention, where strong health systems and access to care and attention to social determinants and environmental determinants of health is important. An establishment of active learning public health surveillance systems and early detection programs, but cutting across disciplines and intersectoral partnerships, easier said than done. And we are trying to study this topic of how to encourage intersectoral partnerships, how to develop alignment of different systems, but continuing the framework of robust clinical research, continuous quality improvement, building capacity for pragmatic studies, pragmatic clinical trials and implementation research at the individual level, and basically prevention at all levels, individual levels, place level, societal levels, policy levels, making it easier for individuals to follow healthier lifestyles, not just giving them advice and hoping they will follow it, because that usually doesn't work. But health systems have to prioritize prevention. Leadership often don't want to talk about prevention because they're in the business of making money from their healthcare system. And it's a business, especially in the US. Expansion of primary care, we think, is extremely important. Primary care that's sensitized to prevention of disease. Health insurance programs can play a big role, we think, to incentivize prevention, because in the longer term, there's a bigger bang for the buck for earlier screening, earlier detection. Health systems need to forge active bidirectional links with communities and social care networks in the public health systems. And then communities themselves have to take responsibility for the health of their citizens. So these are tall orders, but could represent the pillars of prevention. Not just kidney, but any non-communicable and in fact also communicable diseases. So very grateful to many members of my team in the picture here at one of our team meetings. These are folks from the CDC and my own team, National Kidney Foundation, Dr. Joseph Vasilati, and students and trainees. A number of people I have to thank, people who are sources of data. There was a small anti-racism grant, the CDC grant, and many, many collaborators across the university and other institutions. So thank you for your attention. I'll end here, and I'm sure I'm over time. I've not been keeping track. So if there are questions, please feel free to ask.
Thank you, Dr. Saran. Quite an informative presentation. You're actually on time. You're not past time. You've really kept to it. Thank you. And I think I do, from the talk, it has partly answered the question. I think we do believe that a learning public health system is indeed an answer, especially when it comes to prevention. I think also to do with early detection and also prompt intervention. It's good to see what you've been able to achieve, especially in the US, using the Renal data system. I know in sub-Saharan Africa and I think you come to East Africa and specifically to Kenya, we have had challenges just putting up a CKD registry. I think it's something that's a work in progress. It needs also buy-in from the government or Ministry of Health for us to have a national CKD registry. But I think in our own small way at AHN, we do have data that we usually put together just to follow up our patients. But I think it will require a lot of investment, especially on the African side, to do with the IT infrastructure, human resource capacity, and just having an electronic medical record system that will help with the upstream surveillance. But thank you for the talk. I believe it is quite timely, and I'm seeing there's a question from Dr. Amar. Maybe I can take that as we continue. And Dr. Amar asks, how can the KDSS leverage advancements in AI and machine learning to improve early detection and personalized treatment plans for chronic kidney disease patients?
Yeah, Amar, this is a very important question. And certainly we are, even in the US, it's not being practiced in every health system, or it's not readily available. It's only this area is relatively new, but ready for prime time. Again, with a whole lot of caveats that it may not always provide all the answers. It's a very exciting area, and for early detection, we have, as I showed you some data on our early prediction, we did use machine learning tools, and that certainly speeds up the analysis of data as well as. But we don't know what's going on in the analysis part. It's a black artificial. This AI and machine learning are a little bit black boxes for those of us who've done traditional epidemiology and biostatistics. But a lot needs to be learned, and practical demonstrations need to occur before these can be routinely practiced. And certainly integrated healthcare systems where there are good electronic medical record systems, data warehouses, and data scientists of all types, not just the classical variety, but also the modern day computer science trained folks. We are fortunate to have a good access to such people. The challenge is often to bring them all together and to provide the funding and resources to get things implemented and take it forward. So there's a learning curve. There's also then pilot testing, implement. It does take time, just like any other progress. So, but if you have the concepts, I think, and if you have communities that are interested, a lot can be done even in the absence of these tools, the very, very modern tools, I mean. But yes, you do need basics of good data and access to data and retrieval of data. So good electronic medical record, as well as ability to build data warehouses. And we're fortunate to have teams that are doing, in fact, the VA hospital, for VA health system spends more on their data systems than on the healthcare itself. Their budget is huge. I don't know what's going to happen next, but it's things are different. Health systems have different resources, but they're mostly focused on patient care, as you know, and people are doing their own experiments in their own areas. The health systems are not completely aligned with the idea of this early detection business yet, but it's happening. It's beginning to happen.
Dr. Yuri, Professor Sarla Naikar is there, and she's the doyen in Africa.
I see. Yes, absolutely.
Yes.
We'd like her to say a few words.
Yes, certainly. Please go ahead, Dr.
Yeah, I think Professor Naika has typed a question, but Prof, you can just unmute yourself and ask your question live.
She's on mute, I think. So
yeah, she's on mute. Probably. Oh, yes.
Sorry,
No, she's on
am
mute.
I unmuted now?
Yes.
Okay. Thank you, Dr. Saran. I was very interested in your talk, especially. I think you're. Sorry, am I muted still?
No, you're fine.
No, you're okay. You're okay.
Okay. Especially the fact that we're missing all those people with early kidney dysfunction, the ones with GFRs above 60. So I think you highlighted that we should be more cognizant of this. But my question refers to the fact that I think globally we're very poor at implementation of prevention strategies. And one of the things I was wondering, how does a program in the US compare to the global efforts? Because one of the disturbing things is that we see people with diabetes or hypertension for many, many years, and nobody has even checked what their kidney function is doing. And therefore, my thought was that if we did, like, for instance, one of the striking messages about the COVID pandemic, for instance, is that public education was so amazing, so comprehensive, that everybody knew what to do, including, the person who's not even highly educated. And my thought was that in some way we should get the message across to individuals. So I was wondering, how successful are you in getting this kidney prevention message to individuals so they could go to the doctor and say, what is my kidney function? What is my EGFR, for instance?
Yeah, I think that needs to start happening. these programs, these different programs, and if we track sequentially, right from the time the KDOQI guidelines came out first in early 2000s and the definition of CKD. And if you look at data on awareness of kidney disease, at least in the US, for a long time, there was no change. It was just 1 out of 10 individuals was aware that they had, or they had been told that they have kidney disease. For the last decade, there's beginning to be change. So in general, awareness is slightly up now when we look at the data, and we haven't published this yet, but awareness has gone up from, on average, in the US population, looking at the National Health and Nutrition Examination Survey data, which again is a weak way of looking at awareness, but it is what we have, that it's about, overall, it's gone up to about 15 to 20%. And there's some variation across the different states. It's not gone up much, but it has gone up, which suggests that these programs have slowly been diffusing to the public. But we are not seeing public health messaging, and what you're suggesting is missing, conspicuous by its absence. Even in the US, where I see mostly advertisements for drugs on television, rather than public health messages, there's no money in that, in putting an ad for making people aware of kidney disease, I suppose, whereas a drug company can pay $2 million to the television company to put up these ads for drugs that people don't understand. They're just getting information on these medications. So there are no public health messages in general. So that's a problem. That's a problem. And the only change that has occurred is screening of diabetics for albuminuria. So that became a HEDIS measure, or a quality measure linked to incentivized payments by the insurance companies and CMS and others, where diabetics are certainly being screened more frequently. Even there, the peak screening practices are around 50 to 60% of diabetics that present to the hospital or are being seen in health systems. For the vast majority of health systems, around 40% or less. So even there's a gap, despite it being a so-called HEDIS or measure. So and hypertension, only about 10%, 15% get screened, and other things are even. Cardiologists are now telling us, the CKM syndrome, I think that awareness might lead to more screening sooner. But you're right, the messaging is not getting across and has to be more energetic. That's
yeah. I think we do well in things like World Kidney Day, World Kidney Month,
yes,
but we need more of that. Yeah.
Agreed.
Right, thank you for that. Let me just read a question from one of our nurses by the name Elkanah Bryan. His question is on what would you say is the greatest and most important resource in establishment of a learning public health system? Where and what should be the primary focus be?
Great question. we are struggling with that ourselves, but the first thing that should happen is alignment of coming together of people. So formation of a learning community, put simply, meaning from different disciplines, and ideally from even different sectors, not just the healthcare sector, but primarily health systems. So doctors, nurses, social workers in the health system, connect with the communities that they're trying to serve. So identify a zone, a place that you want to help improve the health of, delineate the area that you're responsible for, connect people from the health system with community-based organizations that have direct links, or with the religious organizations that have direct links with the people, and to raise awareness. First of all, I think raising awareness is very important. So repeated messaging, as Dr. Naiker was suggesting, to these places, and then these communities can discuss a strategy based on the healthcare needs of that place. Healthcare needs of that place have to be determined either qualitatively or quantitatively. Ideally, there should be surveillance systems in place that track disease and its outcomes in that area. So based on those healthcare needs, formation of the learning community is a good start. I think that's fundamental. And then you decide what changes you would want to bring. What are the most important priorities? So these groups have to meet periodically. They have to come together on priorities and then begin to develop a plan to act on each of those priorities. But simply put, if you just want to focus on the health system and tackle first the people that are coming to the health system, I think that could be the first step. And even that we find is a challenging piece to accomplish. But it requires energy, enthusiasm, involvement of people at the front lines who are going to make first contact with the patients as they're coming in. If you have, so, as you check their vitals, you 5 minute, in less than 5 minutes, you can determine if they have any risk factors for kidney disease, for example, by asking them a few questions, and then determine whether they need a simple urine test as part of their clinic visit. In primary care, that's what we are trying to encourage, that just like, urine test should be pretty routine. And unfortunately, it's the most neglected test in, blood test is easy to order and people go to the lab. They don't drop off a urine test, a urine sample. And even when requested, and somehow that needs to be built in to health system but raising awareness and doing urine tests more often for early detection. And doing the right test, of course, and the labs have to be part of that. So if a person has a serum creatinine, it's an incomplete evaluation unless they also have a urine albumin to creatinine ratio. So we have lots of creatinines in the health system. 80%, 70 to 80% of people have had if they've presented to health system, they've had lab work, they're part of the panels. But the urine test is not. And I think unless that dual testing paradigm is somehow implemented, raising awareness of that, it takes time and energy to accomplish that. And we are finding that and then if there are no guidelines, so you have to, it's a catch-22. They say there are no guidelines for urine testing. Why should we do it? What will we do if so the awareness has to be raised, and there's a knowledge gap that has to be filled up. And these are the things that you have to tackle. But setting up programs is the first step, and then bringing the right people together, I think, is the next. And then looking at whatever data you have, whether it's in the form of, I'll stop there because I can keep going on this.
Thank you for that response. Just another question that is
Lloyd,
closely tied to that. There's a question by Professor Pascal asking on how should we convince national health insurances to incentivize prevention and screening packages. I know it's a difficult one there.
Yeah, that's a difficult one. You have to show there should be a cost benefit analysis in some way. They're convinced by, so what in the literature, it's very clear that each stage of kidney disease, for example, the worse the kidney stage, the cost per person is higher. And, of course, they want data from the health system that you're dealing with. But in general, that's a repeatedly fairly robust finding. That's if you look at stage 1, 2, 3, 4, 5, and then if you can compute how much dollars, what cost can be prevented if you slow down progression, for example, from stage 3 to stage 4. I think as a first step, just preventing the progression from stage 3 to stage 4. If you can prevent X number of people, and we've done these calculations in the VA, where we could compute the estimated cost for each different for all care for those patients, not just kidney care, but all care, all their medications, all their healthcare visits, and so on. We were able to show that even if 500 people each year are prevented from moving from stage 2 to stage 4, that the VA saves, for those 500 people, the VA will save $2 million. And we said, that can be accomplished pretty easily. Why don't you give us $2 million a year to do this work, to do this kind of surveillance work for the VA? That was the justification we had put in our grant proposal for the following year of funding. And yes, that created a lot of excitement. And but yeah, we didn't get funded beyond the first 4 years of the project because the government changed, and political determinants of health sometimes become very important in funding decisions. And then subsequent implementation. But the rationale, the priority, kidney disease got a lot of leverage in the VA, and they realized that it's one of their top few conditions after veteran suicide, diabetes, hypertension. Kidney disease got a lot of attention, and now it does. I think the VA does very well in caring for kidney patients.
Yes, so the answer there is cost-benefit analysis, quite important.
And yes, either from the literature or from that particular health system, what are these patients costing us in real dollar terms? And also, if you can do qualitative work for quality of life and so on. But I think that's harder to convince payers. They want to see the actual costs being reduced for them.
Saran, I know it's quite an interesting topic, so we still have quite a number of questions coming in. I hope you're okay for time. You can take a bit more, few more questions.
I have a little bit more time. Yes, I can deal with a couple more questions, but I'll be happy to answer questions by email. If there are folks that have questions and we run out of time.
Okay. So there's a question from Dr. Anthony Junda from Tanzania. I'll try and read it. It's a bit lengthy. So he says prevention is always better than cure. The problem comes when a person with a certain health insurance coverage comes to the health facility for general checkup as one of the preventive strategies, but will be denied such a service, as most of the health insurance companies only reimburse treatment expenses and not checkup costs. So his question is, can this be approached, or how can this be approached? I know it's tied to what you just answered. Yeah.
So it's a system issue, and it's also an issue of, dealing with the access to healthcare, primary care system. I think people showing up at a specialist clinic, or if they have access to primary care, I think primary care systems need to be strengthened throughout the world. That's an issue, except in very few countries where they are well established. These are hard things to crack, but person visits, the health system has to allow for a certain number, I think, or reimburse for at least a basic minimum, at least once a year for people over the age of, say, 35, 40, depending on. Otherwise they'll show up at your doorstep when the problem is far advanced. I think the well person check is extremely important, and there needs to be more options available for that. I mean, but the question is how to do that. Is that the question, is how to get to that point? Is that?
Yes. How can this be approached in terms of ensuring that patients are not denied screening services so that we prevent?
So health systems generally are reactive in their approach, not
not proactive.
And
Agreed.
That has to be a systemic change. Again, learning communities of practice, trying to improve, getting together with the health insurance. They should be part of the stakeholder group. It should not be us versus them. Bring them in the fold to talk about their goals are similar, to improve healthcare. So I think forming partnerships with between and involving patients in those groups for discussion, not just people who are treating or dealing with the problem when it arrives, but involving the communities that you're trying to serve, I think would be important to try and convince. And then getting people from the community who've had the problem and wish they had been discovered early. I think case studies that would highlight the need for earlier screening would be very important to demonstrate to the payers and health system organizers. I have to go to my next meeting now, unfortunately. I'm being paid. But I'll be happy to deal with questions by email. I think I might
yes.
Lloyd and yourself, feel free to direct those to me, please.
Yeah.
Agreed.
Sure.
Thank you very much for this opportunity. I'm really very pleased.
Thank you, Dr. Saran.
I'm very excited about the questions that I'm getting, and I wish I had more time right now to deal with them.
Yes, sure. We understand. Thank you for making time.
Thank you so much.
I'll give it to Dr. Lloyd to close.
And thanks very much, Rajiv. Very interesting thoughts, and I think we'll have to see what we can do in the East African region. Place-based and community-based, learning systems. At least one sort of a pilot to see, okay, how things can
Yes.
be done. Because there are
Yes.
some things there, like
You got
the
the main
HIV,
message. Yeah.
the retrovirus thing. That
Yes.
there are programs that run, which actually can be, you can mount on that and sit on that and see what we can do. There are, and place-based where you have high, high incidence of kidney disease and, involving the community, involving the patients, involving, the whole health system in the local region and, highlighting that. Just one, we could try a trial basis in maybe Kenya or in Tanzania and then go from there. Even I see in Zambia there are
Yeah, I think that's a huge opportunity, and that's sort of my main message, that prevention has to start at person level, sure, but place level, more importantly, to have a bigger impact on the population at large.
Yeah.
So thank you for
so very much.
doing that. Thank you.
Thank you very much, Rajiv. Thank you so much.
Thank you, Dr. Saran. Looking forward to having you at another time.
I'll be delighted.
Thank you. On behalf of Africa Healthcare Network and our panelists, I want to wish you a good evening and see you next time.
Thank you very much.
Yes.
It's been a pleasure. Thanks.
Pleasure. Thank you.
Thank you very much, Dr. Naika, Dr. Jacqueline Shaw, for participating. Thank you very much.
Thank you very much for an interesting session. Bye.
Thank you.